Good evening to everybody. I'm very happy to present our company, our technology to this huge audience. So, just few words about the company. The company was founded in Switzerland, South Switzerland, in 2008. After 4 years of R&D activities and clinical trial, we arrived on the market in 2012 with two brands, SmartBone and SmartBone, that they are just two brands of the same material. Then during this last 6-7 years, we arrived also in orthopedic field. So with orthopedic field, we've involved also the oncological, pediatric oncological surgery, traumatology, sport medicine, foot and ankle surgery, and so on. Here you can see our product portfolio. We have the dental line with specific microchips and small blocks. We have also the orthopedic line with specific shape, especially some wedges for osteotomy, for foot and ankle, and so on, for traumatology. We have also some special cage for the neurosurgery, and we have the custom made. So starting from the TC scan, we can reproduce any kind of shape for some specific defect. So let's start to go deep in our technology about our bone substitute. So as you probably know, on the market, you can find several material. The gold standard still remain the material that you harvest from the patient, that you can obtain the best result in terms of success. But obviously, there are several limits in harvesting material from the patient. And you can find also cadaveric material, you can find animal-derived material, and synthetic material. We analyze all this material. Typically, the synthetic material is quite cheap, but also the mechanical and biological performance are very far from the gold standard. While the cadaveric material normally show obviously some limits because the risk of disease transmission is higher, and also sometimes we have ethical problem. We have also some animal-derived material that they show good result, but also some limits. So our idea was starting from bovine bone to try to achieve the mechanical and biological performance of the gold standard. So we start from the huge experience of, as for example, Geislich with BIOS that arrived on the market more than 60 years ago with a bovine bone derived material. And we analyzed that from safety point of view is a very, very good material because there is no adverse reaction reported. So we decide to start with the same material. But as you probably know, they show some specific characteristics. This material, BIOS, is a material that have a very, very good volumetric maintenance, but there is no possibility. If you reopen the site later, we will see some histology. After 10 years, you can find BIOS particle inside the site. So to undergo this kind of limit or this kind of property, we decide to start from bovine bone, but we decide to clean this material with cleaning treatment at low temperature to preserve the chemistry of hydroxyapatite, the chemistry of the mineral part of the bone. So we remove all the biological part, blood vessels, fat, collagen, and we extract just the hydroxyapatite, the mineral part, with a cleaning treatment at low temperature to preserve the chemistry of hydroxyapatite. Then, to try to mimic the human healthy bone, we add biodegradable polymers and collagen fragment to improve the mechanical performance and the biological performance. So about the biodegradable polymers, we use some material that are very common in the surgery, like biodegradable sutures, and this improves the mechanical performance and the volumetric stability of the material. So when the human body reaction starts after the implantation of the graft, only the coating, only the biodegradable polymers is attacked. So in 4 or 5 months is completely resorbed because it's transformed by hydrolysis in water. So there is no strange reaction, but the polymer is absorbed by the body. About the collagen fragments, we use denaturated collagen that express some specific sequences, the RGD sequences. These are kind of hook where the cells from the bone of the patient can connect immediately to the surface of the graft. So, especially the osteoclasts, that are the cells that have to destroy the necrotic bone, the dead bone, can connect immediately to the surface of the graft. So the healing process starts immediately. So why SmartBone, SwissBone is better than other material? Because we show this anatomical selective remodeling. I want to show this picture from patient 1 and patient 2. As you can see, there is a large cyst in the patient 1. In this case, the surgeon decides to open obviously the site, clean the site, and then put some microchip. We start from spongy bovine bone, only from spongy bovine, no cortical bone. But as you can see from this picture, after 30 months, we have replaced also the cortical layer of the bone and all the spongy material. In the patient 2, we can see easier. There is a very thin layer. So in this case, the surgeon decided to perform horizontal augmentation, adopting a plate, a SmartBone plate fixed by 2 screws. And then you can see that month by month, the cortical layer of this bone is moved to the external part, and after 20 months is completely replaced. In the picture on your left side, you can see some histological images of a graft implanted 2.5 before, and you can see that there is no more evidence of bovine bone, necrotic bone, because we can see a lot of osteocytes in the lacuna, inside the lacuna, and we can see a lot of blood vessels. So we can understand that the material is fully remodeled and well vascularized. Obviously, to go deep in this topic, there is several papers that you can download from our website, and you can see also this paper when this process is well described. So here we can see, if you want, a comparison between BIOS and our product, because there are 3 independent studies performed onto 90 patients in sinus lift. The study in the 3 papers is performed just for 1 year. So at the end, they say that the general behavior is quite similar. So there is no strange reaction. There is a good integration. You can proceed with implant placement. But if we go to download other scientific papers, we can see that after 10 years, you can see in the picture below on the left side, the particles of BIOS are still in place. So there is no possibility of remodeling of BIOS, but also other material that were cleaned by high temperature treatment. Here I reported some products that you can find on the market, and you can see that several of these material, by us, but also Cherabon by Botis, are cleaned by high temperature, so they have a very, very good volumetric maintenance, but there is no possibility for remodeling. There are other materials that they adopt cleaning treatment at a low temperature, so there is a volumetric loss, but they can be remodeled in 1-2 years. Our material can show all the advantages, so very, very good volumetric retention, full remodeling, high hydrophilicity, so the material absorbs blood very fast, and later Dr. Fraschini will show you some movies, some pictures. And we have also, especially for the blocks, a very, very good mechanical performance. We have a lot of scientific paper. We are talking about 100 scientific paper that you can download from our site. Just a few words, because and later Bruno will describe better than me. We recommend, for example, to avoid the use of saline solution, because the physiological solution extract the protein inside our treatment. So we have a reduction of mechanical performance and also biological performance of our graft. So the first choice is the blood of the patient. It is very easy to harvest the blood from the patient, and later Dr. Bruno Fraschini can touch this topic. And we recommend also to evaluate the patient before the treatment, because if we want to obtain a full remodeling, we have to evaluate the metabolism of bone of the patient, because if the level of vitamin D is too low and the cholesterol is too high, the metabolism of the patient is not good, so there is no possibility for remodeling. But I want to pass the hand to Dr. Fraschini, that can go deeper than me about the clinical cases. So stop to share my screen and I pass the hand to Dr. Fraschini. Please, Bruno.
Here is it. Can you see it?
Yeah, yes. We can see.
Okay. Hi, everybody. Good evening or good afternoon. Some of you already joined our last webinar, and today we are focused on sinus leaf and preventing complication of this procedure. Is a huge field, and I try to give as much as possible information. Some is concerning surgery, some is concerning biomaterial, and some is linked to the patient selection, which has for all the surgeries very important, but particularly for this procedure. So the presentation, you see how is it divided. So we see an introduction with some cases where we have some complication, alternatives to the sinus grafting, which has many of us know is one of the first and most reported grafting procedure in implantology. A small look at the technique, biomaterials, and how to achieve stable and long-term result. Important of patient selection in this procedure, and tips, surgical tips or follow-up tips and prevention. So here we start with some cases where we have some complication. This is clear and late complication. You can see how poor technique, but also not using quality material, implants or biomaterial, leads to failure. So you can see on the right side, sinus lift, what's happened to the implants. There is implants migration, fracture, whatever. So mostly also it's always better to avoid complication in sinus lift, because then a new surgery in a compromised sinus lift is always more difficult. Another complication that was coming to my attention, this is during internal sinus lift, the summer tonic. You can see somehow probably link to the speed of the implant insertion. So they lost stability and they lost in the sinus the implants, because from the bone height was still good. If you see something like 7-8 millimeter for sure, but probably the bone quality was very low, and the colleagues lost it. In the sinus, here is the picture how I recover the situation. You classic lateral wall antrostomy and the implants and X-ray control after the surgery. It's not a complicated procedure, but it's clear it's a second surgery for the patient, and yes, it's not nice for sure. This is a late complication, for example, of mine. You can see at the time I was using, let's say, wrong biomaterials doing sinus lift, or the wrong procedure. The surgical technique was already good, but you can see is missing the keratinized mucosa. The implants is too large, and the biomaterials I was using was not good enough. So all these factors together, so the patient selection was good, but surgical was acceptable. Wrong choice of material lead to this periimplantitis and secondary sinus infection. I have to remove it all, clear, and choose another option for the patient, because she doesn't want anymore to have another sinus lift. This is something like 15 years ago. And that's why why I somehow think again how to perform this type of surgery and how to select the cases, and not to finish in this kind of situation. Was several factors which gave this result. Here in other cases which came to my attention, you see these implants are quite famous, well known, one of the leading companies on the market, but you can see how a poor technique, wrong prosthesis, wrong planning are giving this type of situation. Also, on the left, you see the left sinus was clear, sinus augmentation, almost 100% done with xenograft, and that's why the patient is losing from the tissue from around the implants these classic bone chips, which is more like a stone. You press the gum and it's getting out this material. It's clear that the graft is not stable, it's not vascularized, and she will lose soon the implants. What is it? So this is the classic sinus grafting, which is one of the most used procedure in implantology. This is a case of mine. You can see the right surgery, the right biomaterials, also the prosthesis. All these implants are working since almost 15 years, 12 years. You can see the surgery, the type of bone window I use, very stable, and after 12 years, this is the gum situation, and also the X-ray that I just saw it. I lost something 1.2 millimeter around the implants, which is not so bad, also considering that the patient is 84 years old right now. So when you decide to perform a sinus lift, what is very important is the patient selection, not just the local contraindication, but systemic contraindication. You have to check the morphology and physiology of the sinus, and you have to consider the complication. You have easy manageable complication and complication that you really want to avoid. Let's see some complication. Fast, you have the Schneiderian membrane perforation, which it happens to all of us surgeons who perform this type of surgery at the beginning, or also in later case. The most complicated case are normally women around 40, 45 years old, very healthy, without history of sinus complication or sinusitis or nose disease, because they have very, very thin Schneiderian membrane. That is so easy to perform that sometimes you have even to close the window and decide to do another surgery. So it happens to me one. Schneiderian membrane, somehow in 90%, 95% of the cases, you can manage it after a while. It's important is how big is this perforation, clear. Today is difficult with many things, many topics, so I won't go in details, but it's something reasonable that you can still go on. And you can see how is it the incidence of this complication around between 20 and 25%. Depends, on the searcher, how clear is the complex decay septa, or how thin or scar tissue. One of the funniest things in the patient selection that you have past heavy smokers, so that they should not smoke again, clear. But they have thick membrane, so normally you never perforate an ex-smoker, a past smoker. So the problem of the perforation is that then for grafting, you cannot graft the sinus in this situation. Or you close it with a membrane, or you stitch it, or you are able to make a sort of punch and still perform the sinus lift. If not, the graft material will enter the sinus and you will have the problem that you can see. It's even better if you're not able to close the perforation to interrupt the surgery. Okay. Acute sinusitis is a typical example. Normally you have a big swelling after, the swelling is not going away after the surgery. So somehow in 2 weeks time, you still get the swelling and you can have, it's red, the cheek is red, and you can have fever. That's the two symptoms, fever and swelling, which is not going away. You have to clean all the graft, clean the surgical site, remove everything, and clean it, antibiotics. Still, you can see how high is the incidence, 10%. Pain, as I told you, swelling, congestion, smell, antibiotic therapy, drainage. The drainage is an old surgical school method, but for a dentist or a surgeon who want to perform in case of sinusitis is the best solution. That's an old technique, but it's working very well. If you don't resolve it, you can have a chronic sinusitis, as you can see in the left sinus is completely obliterated. And it's even more complicated. You have to send to resolve it, so it's better to send it to the ENT for a check and deciding what type of therapy he can go on. Another is bleeding, but this is linked mostly to this artery. This is alveolar antral artery, which is an anastomosis between the posterior artery and the infraorbital artery. In some patients, it's very thin. You don't even see on CT. You cannot see during the surgery. In some patients, it's thick, and this patient of mine was quite thick, but still we have done the sinus lift without any problem. But you have to be careful with the bleeding, and that's why it's mandatory to have a CT scan and be able to read it. You cannot perform a sinus lift without a CT scan. Right now it's impossible. I remember when I started, was not the case. Everybody was starting with a clear radio, a panorama, let's say, without this three-dimensional X-ray. But right now we have it. We have to use it. Another this is clear, the graft material displacement is linked 99% of the cases, sometime to the snoozing of the patient, but 99% of the cases, because there is a perforation of the sinus membrane. You have to be careful when you do the elevation. I have to say that somehow the technique of the elevation, sinus elevation, is not that difficult. There is some tricky tips to do, but the center point is always the same. If you read carefully the CT scan, will be not that difficult. It's the patient selection and the material selection that you have to be really, you have to follow a clear path, not to go around, I do this, perhaps I do this. No, make a clear selection. This is a link, somehow wound dehiscence is mostly a surgical problem if you don't have infection and you need to perform a good realize of the gum, of the tissue, you need to stitch properly, you need to give the right explanation for the caring after to the patient. But this is mostly linked to the surgical link. And is a problem because then there is a higher risk of infection, not because it will heal, but the risk is the infection. And then the infection of the sinus, which is the thing that you have to avoid as much as possible. Implant and graft failure. That's why mostly for what concerns the implants is linked to the biomaterial that you choose. You have a poor biomaterial when you do the second surgery. What is the graft is not bleeding, is not vascularized, and without bleeding, the implant will not. You won't have an integration, and you will lose it for sure. So this is a fistula, again, normally linked to poor surgical technique or infection. You have to open it, you have to clean it, you have to give antibiotics to the patient, and you cannot leave it like this. Like the wound dehiscence, you have to close it. Pain and swelling, this is a symptom that, as I told you, is quite important to recognize. If the swelling is not going away, slowly going away after 4 or 5 days, it means that something is building, in the wound, which is infection. And my suggestion is to perform a CT scan and to see if the sinus, what is happening in the sinus, is completely obliterated, or you have still some is manageable. You can increase the antibiotics, but you somehow, my suggestion is to have a daily check of the patient. If it's going away in 4 or 5 days, it's fine. If the fever and the swelling are there, something is wrong. And what is very important is to have a fast reaction, not wait. Don't wait. It will be worse in the sinus graft. In some other grafting, it's still manageable. Allergic, body reaction, I never see it, but yes. Ultra cessation, here is again linked to the surgical technique. Infraorbital nerve, it's useless to go so high. On the lap elevation, or when you try to move the lap for the closing. Is not necessary. I never have. From what I remember, I never have. In this case. So, and also the nerve is very thin. So don't go that high. It's not necessary. What is very important is to move fast, act fast if you see some complication in the sinus graft. Let's see the alternatives, which are, there are some, and some that I don't like. So Because if you perform a good sinus lift with a good patient selection, you have a high chance to have a stable graft in the long term. Other solution that we will see together right now is, I'm not so sure. If you have any question, please write. We will try to answer at the end. So, the sinus lift is evidence-based. There was already a conference in 1906 about sinus lift and the data and the collecting. But here, let's see, short implants. Short implants, this is a case that is not my case, but you can see there are several things that I don't like. Already you have a bone resorption, the first implant, mesial implant. You have a too high ratio, crown implants ratio. The two implants, the two distal implants are too close. You can see the keratinized tissue on the last teeth is already compromised. So with the short implants, I use it, but if I can, for example, if I have a bridge like this, I try to have 2 longer implants and 1 short implants, but 3 short implants like this is a risk, okay? Even if studies report good result. Another, tilted implants. These I like, for example. This is a solution, elegant solution, which give you the chance to let's say, to have also very stable prosthetic rehabilitation. You use a quality bone for the implant insertion. You can use very long implants. So just read the CT and decide if it's feasible. Is a wonderful solution. And it's very stable. Clear, the prosthetic work must be proper. Another solution is pterygoid implants, like this one. Better to manage after a good anatomical knowledge of the area. If not, you will lose also in the infraorbital area, the implants quite easily, or you can have heart bleeding, not easy, with the not easy solution. So possible, but not that easy. For my zygomatic implants, like this case, the incidence of soft tissue problem is between something like around 20-25%. It's very common now. You see a lot of advertising also on social media. I have to say I don't like this solution, because if you have a problem, it's far bigger than a complication in the sinus lift. It's far, far bigger. Clear, you can, most of this solution is used for immediate loading. Okay, so that the implants come in the office and go out the day after, 2 days, whatever, the same day with a fixed prosthesis. But the risk and the complication are quite high. It's useless to go around. Everybody knows it. But still, there is a lot of advertising for this type of solution. And here we are at internal sinus lift. This is a very good approach when you have a cortical basal cortical bone, at least in my personal clinical experience, around 5 millimeter. Around 5 millimeter, you can reach 3 more millimeter and you are at 8. Less than 5 is becoming tricky, because if you have also perforation, you can see. But if you hit a thin Schneiderian membrane, you won't see it. You have the perforation immediately. So my feeling, it's 5, the limit. And choose the easiest and with the better benefit for the patient, with complication and, for example, tilted implants. Not for sure zygomatic implants. I prefer a sinus lift. So this is not a classification. This is how I do as a clinician. I prefer the surgery. I divide the two different types of situation, 3-4 millimeter of basal bone or less. With 3-4, I perform also, I place the implant at the same surgery. With less, I prefer after 5 months because the implants will be unstable. Check always the relationship between the upper jaw and the lower jaw. It may require vertical bone augmentation and the flap design. And trust me, this is the classic bony window from Caldwell loop, modified Caldwell loop procedure from Boeing. And I use a piezoelectric bony window osteotomy. It's very thin, it's very safe. It's very difficult to perforate. Instead with a burr, if you're at the beginning, I suggest this one. Then you can go with a burr, but then it won't be thin anymore. Is my standard procedure. And you can see here, you can design, it takes a bit of more time, but you can design the window as you prefer. It's very clean. The bleeding is very, very small. So here you can see another one. You can choose, even if it's thick, like in this stage, it's thicker, the bony window, but it's not a problem, really not a problem. Just works smoothly at the beginning, if your first cases, and then you can go fast, and you can place it again. So that's why that we have a general aspect of the complication and alternatives. And how I do this we have to, yes, we can speak about flap design, but it takes a lot of time because depending if you put the implants, if you don't put the implants, at what high this bony window, I keep 3 millimeter from the cortical bone, how to engage the front, the anterior bony wall of the sinus, the many technique, but not that complicated at all, somehow. If you perform this bony window carefully, then everything is quite easy. So, materials. As I told you, I start that case that you see at the beginning. I start doing the sinus lift just with xenograft. With xenograft from Geistlich, which is a very good product, stable, almost, it's very stable. It doesn't give you any sense of easy infection. Let's put in this way from the clinical point of view. But I saw some problem, as I show you. It's not possible to do a sinus lift just with Geistlich or with xenograft. It's not possible. I don't think it's reasonable. It will come for sure some problem at the end. And here, as Gianni was saying, the autogenous bone, the bone chips here that I harvest from the lower jaw on the retromolar area, is the bone chips is not mandatory. Yes, for me it's mandatory on sinus lift grafting. It's the gold standard because it's osteogenic and give you a big kick for the remodeling in this type, because the sinus, you have to think that maxillary sinus have a low vascularization, very low. From the wall, you don't have a lot of bleeding. You have the bleeding from the gum, but when you close the window, the bony window, at that point, the bleeding somehow from the gum is stopping, and you don't have the cells from the bone that you need for the remodeling and for the bone formation, for sure not from the gum. And the sinus, it has a poor bleeding up if you don't cut the artery, okay? If you cut the artery, you have a lot of bleeding. But that's why I changed the type of grafting. I need some autogenous bone. You can see also if you have tori, you can harvest from the tori, you can harvest from the tuberosity, and allograft. Allografts are also very good, but I have to say in Europe, for ethic reason and from infection, are not so common. I know US are far more common, and I use it, but it's not so satisfying, was not so satisfying. So I prefer to leave it. Alloplastic graft, also I use this type of material, but it doesn't give you somehow, in my personal experience, not much, really not much, just a bit of volume. But then you can have even problems. And xenograft, depending on the type of xenograft. As I told you, I start just doing bone grafting, sinus grafting, just like this, because I learned in this way at the university, and then I shift after I saw the result. The result was they were unsatisfactory. So here the type, you can see this graft is a comparison and a summary. Osteogenic, osteoinduction, and osteoconduction. Gianni was speaking about it. And here, enhanced xenograph, the IBI bone grafts, SmartBone, SwissBone, depending, has, I love the product when I mix with the bone, autogenous bone. When you mix for the sinus graft, I think is the best solution, for sure. Because you have a great biological activity, you have the kick somehow like, here is it. Also, you have to consider, this is a quite important consideration. If you do a graft in the front area, because you are doing an immediate implant placement after, for example, a fracture, in that area, it's very important that your graft support the buccal bone, and then with the buccal bone, also the keratinized tissue. In this case, the use of the type of material like as we say, ghastly or xenograph, this type of chips, stony chips somehow, it helps you at the beginning because the turnover is so slow that the buccal bone somehow, and this material stay there, this material giving you the effect of holding the buccal contour. But in an area where the sinus, you need loading, you need infection, somehow defense. No, you need that your bone around your implants is stable, is not just inert. In that situation, you need remodeling as fast as possible, let's say 6 months, 1 year, and that's what SmartBone, IBI bone, is giving you. PRGF and PRF, I like to use them mostly when I have infection. Why? Why? When you use bone chips, autogenous bone, you have somehow these factors in your chips already there. When you scrape it, or when you trifine, you use it, you have it, so it's not necessary. It helps a lot in case of infection. You see also this technique was quite famous from Professor Lundgren from Lund, Sweden. He used also this graftless technique. You can see on the left side. I don't know. I didn't try. I'm not so sure it's working. But he has cases done like this. Paz was patient who has a good bleeding situation, but I'm uncomfortable to think to use this type of grafting. So let's go back to the grafting material. You can see on the left side an autograft, autogenous bone. Xenograft, this is ghastly by us, and IBI bone graft. This is not mixed with autogenous bone graft. This is just blood. So think about if you put this type of graft in a sinus, which is going to be remodeled. You have a fast answer just looking at this picture. One of these three will never remodel. The other one for sure. If you mix with the autogenous bone, you have even a better effect. So because you have the scaffold, You have the induction, and you have the osteogenic properties. So if this is a suggestion, clinical suggestion, if you have complication during surgery, better to opt for a second stage surgery. First, the grafting, even if you have 4 millimeters of cortical bone, if you have a perforation, do just the surgical stage of grafting, and then the implants, because the implants will add a risk of infection to your surgery, and you have already a higher risk of infection due to the perforation. So you have to reduce this risk, and the only way to reduce this risk is to do it, or you close the surgery, you decide, we see us in 2 months' time, giving the time of the Schneiderian membrane to somehow recover, or you do a second stage surgery. Okay, that's my suggestion. More complication, if you have a complication like a perforation, wait more months, not 5, 6, 7, so that the graft is stable. Clear, if you use xenograft like BIOS or this type of xenograft, doesn't change a lot. Yes, perhaps, if he's bleeding a lot, but I don't see changing. You see from the first picture. And this is also a point. If you have perforation, if you feel something is wrong, increase a bit your bone chips. Why? In case you are not able to close the perforation properly, you're not so sure, 100% sure, because you have a perforation, you don't know if you manage it in the right way, you don't know whatever, you are not sure if you will be able to close properly. If you use autogenous bone, the reaction of the body in case of this type of complication, what will be? Resorption. You will have a resorption, not an infection or a graft inside the sinus going around. It will be easy for the body. If something is not working, you will have resorption, and not somehow a sinus graft with some complication. Bigger the xenograft, wait more months. If it's just one teeth, it's easier, go faster. You need less material. You have perhaps you are placing a first molar, you have a second molar, you have the bone on the back, so it will be for sure easier. And also it's the way to start. In my suggestion, if you want to start with sinus lift, try to find a case where you have one teeth missing. Here I had a perforation, I close it with a membrane, resorbable membrane, and at the end the sinus lift was completely, you see just two teeth plants placed. But in case you are not able to manage, leave it like it, you can retry. What is very important is to have keratinized mucosa around the implant, not just bone, not just to have biomaterials that is working, but to have keratinized tissue. If it's missing, you need or a connective tissue graft, but it's very easy. For example, in the molar posterior area, you'll have a lot of tissue on the palatal aspect, and you can move it, how you can see in this picture. You can move it when you do the re-entry, the healing cap connection. Like in this case, after 3 weeks, looks horrible. After 10 days, after 3 weeks will be perfect. And it helps a lot to keep seal your implant and your bone under. So what is it? IBI bone graft. Gianni already explained the advantage. Okay, we try. So this is what I like really of this product, is this highly hydrophilicity. When you mix it with blood, you have immediately the sensation how fast the material is sucking the blood. And you can imagine how it will work after, because you can see here, you have a video. I just add blood, and this is the classic, what you will see. Holding, just all the material holding on the elevator. So do you think you can do, just imagine if you think you can do it with other xenograph like BIOS or other products. So there are many, as Gianni was showing. Is the only product who give you this type of properties. So osteoconduction, osteoinduction, and the other point is this remodeling. The remodeling in something high, half of your graft will be substitute from the autogenous bone in 4 or 6 months. That is fundamental for sinus grafting. As I told you, in the anterior area, you can manage somehow. In that type of grafting is really a huge limit if you don't have remodeling. Huge limit. Not just the beginning, because you don't have to see the surgery just after 1 year. They look almost nice all the time. After 5 years, 7 years, 10 years. That's why. Here are the quality we have. It's very easy to handle. When you mix it with blood, it's very easy to handle. You can place it wherever you want. You don't lose around like other product. And as I told you, one other very important quality is, yes, autogenous bone is very important for sinus lift, but in older patient, in patient who doesn't want to have a second surgery area in the mouth, you can convince them telling that the quantity will be as small as possible. So with and you're quite sure with IBI bone graft that you will have still a wonderful result. Okay. And after the remodeling, you have a bone which is very stable, very stable. Why? Because it's vascularized. It's not some stone without blood. Okay, so Gianni was speaking about the multiple size and shape on demand. Clear on demand is not for the sinus lift because the cavity is always changing. Always use quality material like I show you the X-ray at the beginning. This is how I collect blood. Is quite easy, especially if you perform a sinus lift. Is bleeding in that area. The gum, you are cutting the gum, you are doing the bony wall window. So here is it, a video how I collect. This is the patient lost a central incisor for a fracture, and after the extraction, I perform an immediate implant placement. You can see the collection after the extraction. It's enough. That quantity, it's enough. It's enough for your here in the premolar area. Another case, I don't see any complication for blood collecting. You can see, just use, because it's very important. Yes, this Gianni was stressing, don't mix with saline solution. It's not, you're destroying the material. But in mouth, whatever surgical site you are performing, it's quite easy at the right time to collect blood. So as I show you, I have other video to achieve stable. What to achieve stable and optimal result? You need bone, like this famous article, Uli Grunder and Buser, so at least 2 millimeter bone around your implant. Soft tissue, this is for Linkevichu. If you have less than 2 millimeter soft tissue around the implants, over the implants, you will have a bone resorption, a cortical bone resorption if you have less than 2 millimeter of soft tissue over the bone. And that's very important in the area of the sinus leaf. You can do this. There are different type of flap you can do at the reopening. At the time you connect the healing cup, many ways you can roll it, you can move it, you can use it from the tuberosity, whatever. It's more difficult on the lower jaw, but still, that's one of the biggest point. Soft tissue around the implant, thickness. You can a bit place deeper the implant, but it's not the only thing. You risk a resorption. It's clear also have a huge influence, the implant, the type of implant, abutment, implant connection, switch platform, how high is the abutment, and the contour of the crown. You have many options depending on the implant design, but right now I think we know. That's why it's important to use a good implant with quality tested. Not just, you have to use a good surgical technique. Very important, the case selection, patient selection, soft tissue management, bone management with biomaterials and implants and prosthetic. All these things must go together to have stable result, long-term stable result. Here we are, for example, after a bone grafting, you see the thickness of the bone. You see on the buccal area that I screwed is a type of bone graft, and inside I was breaking bone chips and SmartBone. This is the type of thickness, is even not too much, but let's say you need thick soft tissue and implant. The surface, the implant design, clear, the healing cup, all as I told you here, we will discuss all these steps need to have, you need to have a stable solution. What is the most important? So for closing this part, what I'm looking for from biomaterial like SmartBone, what is giving me? Bone remodeling. After 5-6 months, already half is becoming autogenous bone, vascularized and stable, not just inert, especially in sinus lift. So, how to prevent clinical complication in sinus lift? A clinical approach. This is not somehow, it's not that I have done 2,000 cases, but is in the clinical, my clinical experience, these 20 years. Cause a sinus lift with the sinusitis or with an infection is a no-fault situation for you and for your patient as a clinician. And it's very important to avoid, the only way to avoid this type of situation is to prevent it. So if you want to prevent it, the first step must be patient selection. Then you choose the right biomaterials, then you choose the correct surgical approach, then you choose the follow-up, the implants, the prosthetic. But patient selection is the first thing. So CT scan is mandatory in case of maxillary sinus lift. Because you can see in 10% of the cases, you have a sinus which is not healthy. If you perform a sinus lift, in these cases, you will have a failure, which is not just a small infection. This infection can spread quite fast, and patient must be then hospitalized for weeks, if you are not lucky. So 10% of the cases, CT scan mandatory, because you have to see if the sinus is healthy or not healthy. We will see after some clinical tips how to do it. Patient selection. Don't try it. You have some systemic or local contraindication. You know them, you read it, you have to avoid them. You have to avoid this patient. Is a problem. They are a problem for a sinus leaf. It's useless. You are going to have headache from this. Has no sin. Sorry, has no meaning. So heavy smoker. If you give this somehow, this break, this holiday, no, you do 15 days before, 15 days after, this thing, it doesn't work. Heavy smoker will give you problem for the healing. You will have problem after. You should avoid it. So, a patient who has clear bisphosphonate, chemotherapy, radiotherapy, is clear depending on the area. It's easy. Just check with the doctor who is following your patient. Just check it. Can we go? We cannot go. That's it. It's clear. Hypertension. Right now, most 80% of the patient take some pill for pressure, whatever. Is manageable, depending. You have to find out. Also, for example, here in these steroids, be careful. Steroids, right now, you always find somehow, if you have to make many questions to the patient. Do you have surgery? How many years ago? How long? What was? Did you take? What type of drugs did you take after? That's what you have always question before you decide to go for a sinus lift. Another here, local contraindication. This is quite clear. And this is, for example, we start to see more in detail about the sinus list. The osteometal complex must be open, If is it closed, forget it, sinus lift. If you have septum deviation, better to ask the ENT colleague. You say, look, I want to perform a sinus lift. You say, can you advise me? Is it possible in this situation? Abnormal morphology, concabullosa, we will see after some X-ray, so I can give you some detail. Haller cell. They are not absolute contraindication, but if you see them, better to have a second opinion from ENT colleagues, okay? Uncinate process. Okay, so let's see. Ethmoidal bulla, then clear. Tumors, post-traumatic polyps. A story of allergic sinusitis. This is quite common. Or don't perform. It's not that if the patient is allergic, the seasonal allergy, you can do it, but not in springtime. Do it in wintertime. And the medication also, you can use local steroids and systemic. You have just to choose the right time. Or odontogenic sinusitis. These you have to be careful. We will see. Clear, if you have abnormality, and leave it. Radiotherapy, again, sinusitis, be careful. Sarcoidosis also. So here we are, tumor, patient selection. Clear, this is the clear disease. Xerostomy also has an important role. I would leave it. Clear, lichen planus also. You need healthy patient for sinus list. Two main questions. This is the clinical approach I use. So, is the sinus healthy and functionally competent? It means that the osteometal complex is open and is working. The physiology of the sinus is working. And because during the grafting, you're going to modify the sinus, and modifying the sinus physiology is giving problem if you don't resolve this temporary closure in 10 days time, 1 week time. So the sinus must work again after the sinus graft. You can see different type of X-ray that you should be careful going from the left side to the upper lowest right side. So when it's complete opaque, when you have opacification, you have calcification, which is a normal fungal sinusitis, or you have also aspergillosis, clear. When you have something, when you have a thickening of the membrane of the sinus more than 3 millimeters, ask for a second opinion. Don't go for a sinus lift. Here is the ostium. So because the osteometal complex is not just one structure, and the maxillary sinusosteum must be pervious. So sinus drainage. Here you can see the infundibulum, and this area must be open. Absolutely. If is like the other, also the right side, one is completely closed, not possible. The other one is closed, and you can see the thickening. In this case, you have to send it to the ENT for check and decide what type of therapy to do before. It's quite common because many patients don't even realize it. In the CT scan, the right view that you need, I go back, sorry, try to go back, too much, is this view, the coronal view. In this way, you can see if it open. From the axial point of view, yes, you can still see it, but it's not so clear. That's the view that you need to see from the CT if is it open or not. If it's open, the natural way of cleaning the sinus. How is the movement? And that's why ostium open, ostium closed. When ostium is closed, forget it. Second opinion. If you have a thickening less than 3 millimeters, you can still go on. Exactly. So if this Schneiderian membrane, you can work on the other way around. If you don't see it, it means it's a healthy sinus, and you can perform it quite easily. It doesn't mean that if it's thick more than 3 millimeters is a pathological sinus, but perhaps it's better to check it. Okay. We go on. For example, we see also odontogenic sinus. You can see this molar. This is the palatal root, and you can see after the colleague was performing the root canal therapy, was after the resolution, also the sinus was again normal. So always don't perform sinus lift if you have closed teeth with this type of problem, not just complete opacification, of the sinus, but also if you have, because the infection going around very fast, and you have the window, this lateral window that you open, quite easily you can have infection spreading there. So the premolar area, also the canine area should be fine. No apical problem. Okay, so aspergillosis, it happened to me also, not for a sinus procedure, luckily, but it's difficult to find out where it's coming from if you have, it was a patient from a colleague, all the 2 molar and 3 premolar have root canal therapy close to the sinus floor. It was very difficult to understand which one was the problem and the aspergillosis from the material that was going in the sinus. So this is quite an absolute contraindication. You can see, I show you my case. follow-up mandatory, but this was not a problem of follow-up. This was a problem of wrong biomaterials, missing keratinized tissue, wrong implant, so some mistakes. This is not a contraindication. The retention cyst is not. Is one of the few. If it's not huge, if it's huge, yes, you have to do the aspiration before, if it's huge, because then you cannot elevate. Yes, you can elevate, but it's too huge. It's better you do a two-stage approach. You do the aspiration of the cyst, and then you do the grafting. If it's not that huge, like in the picture here, this is already, you have to see also the other axis. You have to see also the other CT, but it's not that huge. You can easily aspirate, quite easily. And then you can perform the Schneiderian elevation. I have never a problem. I have to say, once like this, I prefer to do a two-stage surgery. First the aspiration and then the graft. So you avoid the risk of infection, whatever. Prothetic risk. This is another huge story. No cemented prosthesis, please. No cemented prosthesis in sinus lift. Cause you know exactly. So just screw retainer prosthesis. If not, you're going to, if you have even the smallest problem, you're going to have problem on the graft. If you're going to have problem on the graft, you're going to have problem on the sinus. So completely useless. The other things is provisional prosthesis. Be careful. Avoid quickly setting of provisional prosthesis. If not, the pressure will have some problem on the gum. And then also you can have a problem on the graft. So better to avoid. Implant platform switching. This is also a big, huge point. Now is everything is, you see from my cases, there was no platform switching at all. And the crown was over contour. So avoid this thing. Anatomy. Let's see fast here. The ostium must be open. I'm sorry, I'm going fast. There are many concepts. And so Hock process. The ostium is becoming smaller. And in this case, you have to be careful. On the left side, you can see it. In this case, if the ostium is too small, the drainage from the ostium will be very difficult and it will close. If it's closed, you have problem with the infection. You will have an easy infection because the bacteria will stay in the sinus and close to your graft. So in a case of Hock process, please send to the ENT. This is not always, but you can see. Let's see. No, sorry. There is no indication, but just under the orbita is that the Haller cells. Just under the orbita. Sorry. Okay, just under the orbita. It's bigger, but it doesn't mean that the ostium will be smaller. In this case, yes. So you have to see if it's manageable or not. You have to decide with the colleagues if it's manageable or not. In many cases, they don't give this type of actor of closing the ostium. Another type of anatomy is septum deviation. This is quite common in the population, still is open here. So, but check it. Sometimes it moves all the anatomy of the sinus, of the wall, nasal wall. Concha bullosa here is regarding clear the anatomy of the nose, but it has influence also on the ostium. Again, bonis, the septa. This is quite common, something like 30%, 20%, but you can evaluate them on the CT scan. On the CT scan, you can see easily and go slowly with your sinus elevation. That's we were showing before. How is it? The bleeding of the artery. You can see here the different view. Be careful, no clinical tips. clinical tips. So the ostium must be always open. So use corticosteroid, local or systemic. Is very important, the antibiotics, and to give good indication after the surgery, not to sneeze, not to go swim in the same weeks. So it's very important to give an antibiotics a high dose. Forget it, small dose, high dose. And if you see some complication, you have to act fast. This is an algorithm how to treat in case of complication and prevention and management. So CT scan is very important. Patient selection is the second. So patient selection with CT scan. If you need a second opinion, do it. Don't go for sinus lift just if you are not sure. The surgical technique is very important. If you have a perforation and you're not able to close it, leave it. Do a second time. Try to be as less aggressive as possible. Do a second surgery. So place the implants if you're not sure the membrane is intact, or if something went wrong or whatever. If you're not sure 100%, go for a second surgery. You have less risky operation. And use the right biomaterials, okay? Try to make the small windows as possible. This is true if you are experienced. At the beginning, if you make it bigger, better is it. And try to open it from the anterior wall, okay? And leave at least 3 millimeters from the cortical bone. So your window is not so close to your incision, the gum incision. If not, it's too close, you have the risk that the bacteria from the mouth during the healing, before the gum is closed, is getting to the window, the bony window. So you have to leave at least 3 millimeters. Because even if your suture technique is perfect, you will have this type of problem. So exactly, you have perfect surgical technique, you have the perfect material, but if you have the wrong patient selection, something will go wrong. Good.
I try to, you describe properly, but I think that is very important to underline. You say that also in the sinus lift, you prefer to use the TC scan with respect to standard radiography, because why it's very important to understand the shapes of the sinus.
Because you have somehow, one is linked to the patient selection. If you have some anatomy alteration, like we saw at the end, this concha bullosa, this septa, this whatever type, this artery, you need somehow, or some other, this Hock process, you need to know in advance if this is the right, if it's open the ostium. This is the main question. Is it open the ostium? Is it thick, the membrane, or is not thick? So you can do the patient selection. This is the first step. The ostium is open, yes or no, somehow. Second, after the surgery, the ostium will be still open, or will be it closed for a while? This is a very dangerous situation if it's going to be closed. So that must be avoided. So the second question. So if you say, okay, the ostium is open, the osteometal complex is working, the membrane is not thick, so I can go on. If one of these answers is no, you have to stop it. Don't do the procedure. Search further, send it to a colleagues, and you decide. Second is because you need a CT scan to plan your surgery. You have to see where you're going to do your window, your bony window. So you have to see, to decide if you have a septa, exactly when you want to do the bony window. You have to see the type of shape. So how many millimeter of bone you still have.
Okay.
So if you do 1 surgery or 2 surgery step, then if the artery is there, where you place the window. Okay,
Yeah.
so how much big is going to be if is it a large sinus or if it's a small sinus. So all these things, if there is this cyst, that you can do the aspiration or not. So somehow you can already decide what type of surgery you will do it after. And that's why it's mandatory. It's mandatory. If not, you start the procedure, you don't know if is it the right patient. You don't know if there is a septa, or perhaps yes, perhaps no. You don't know if there is the arteries there. You don't know if some teeth perhaps need a root therapy before. So the CT scan is mandatory. No way. No way.
Yeah.
No way.
Yeah. Good.
Yeah. This is
Any other question, doubts from the platea?
Hi.
Hi.
Hello.
Hi.
Hi. I have one question. Thank you for your outstanding presentation. So I have a question about what size of particular bone graft
Yes.
is most adequate in sinus augmentation. What size of a
Which
particular bone?
size?
Yes.
Which size I'm using, right?
Yes.
Yes, which size I suggest. Let's say I use I've used both the smaller size of IBI bone graft and the bigger size. I have to say that I find myself better with the smaller size. That's why I find it that mixing with the bone chips from the patient, they somehow look the same. I don't know from the remodeling point of view, but I think is I get the feeling that it's easier to manage when you pack it in the sinus after the elevation, okay, because it's smaller. It's behaving like the bone chips because have the same size when I scrape it from the ramus. And also, I have the feeling that the smaller size has less sharp edge than the bigger size. And what is very important when you pack the graft, the biomaterials mix, that you don't have too sharp edge, because sometimes they can scratch the membrane. When it's very thin, the membrane, sometimes you can also, if you pack in the wrong way, you can open it. You can open it when it's very thin. When it's thick, you can do whatever you want. Like I told you, with heavy smoker, past heavy smoker, you can do whatever you want. When it's very thin, it's important also how you pack it. And when you pack it with the right size, which I think is the smaller size, you have less chance of scratching it, the Schneiderian membrane. When in few cases, when I was not sure, that was so thin that I was not sure, I even place a small collagen membrane on this Schneiderian membrane, has a protection, has a shield. Okay, so when I know when I pack it, I'm not going to break it. This also has another suggestion. When you see it's very thin, I have a patient that breathing was opening the membrane. Breathing, I say, it's not possible. I was astonished. I elevate and it's breathing and it's opening. I have to do a 2-stage surgery. And I told him, look, I need something like 80% of your bone because it's going wrong. It's going to be resorbed because it's opening here and there. I tried to dissect other area of this membrane, was no way. So if you have the feeling that it's very thin, use a collagen membrane as a shield, and my suggestion, use the smaller bone graft on IBI. So you have less sharp edge, which so they don't scratch your membrane, Schneiderian membrane. Yes.
So thank you to everybody. So later, if you want, Arianna can share also the link or on our YouTube channel. You can find the full video. And obviously, you can also write to your dealers or directly to us if you have additional questions, doubts about clinics or product without problem. So thank you to everybody.
Thank you.
Bye-bye.
Bye-bye.